Hello and welcome to this important webinar on the use of genomic profiling to inform comprehensive treatment planning for women with early stage breast cancer. Today's educational activity has been funded by Agendia and is being hosted by EMG Health. I'm your moderator for today. My name is Jonathan Sakia, and I'm proud to serve as chairman of EMG's Medical Advisory Board. For our discussion, I'm joined by two renowned experts in the field. We certainly couldn't rely on me. We'll start with a presentation by Dr. William Audere, who's the Chief Medical Officer at Agendia and a medical oncologist specializing in breast cancer, who has 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Medical Center in Los Angeles, a wonderful institution where I worked as a surgeon many moons ago. In addition to his illustrious career, the good doctor is an accomplished guitarist and could have had an alternative career fronting a classic rock band. So rock on, Dr. William Audere.
Thank you.
We will then hear from Dr. Alberto Montero, who's the clinical director of the Breast Cancer Medical Oncology Program at University Hospital's Seidman Cancer Center and an associate professor of medicine at Case Western Reserve University School of Medicine in Cleveland, Ohio. When the good doctor's not busy being an oncologist, he tells me that he enjoys practicing the art of kendo, Japanese sword fighting, at his local Cleveland dojo with his senseis. And I believe the appropriate greeting is Satsu, Dr. Montero. So from these presentations, you can expect to learn about two of Agendia's assays, the MammaPrint and Blueprint for estrogen receptor positive patients. Highlights will include the latest data to support each assay's utility, as well as information to support their real-world impact and use in various settings when dealing with breast cancer. Following the presentations, we'll be coming together for a live Q&A session. I should say before that, actually after the presentations, there's going to be some case discussions by our two experts. So please, for the live Q&A, do ask your questions throughout in the question box, which I think you'll see at the bottom of your screen. I look forward to posing these to our experts at the end, and we'll endeavor to get through as many as possible. And with that, I'll hand over to you, to our first speaker, Dr. William Audere. The floor is yours, sir.
Thank you very much. We certainly very much appreciate the opportunity to discuss our data with you and then also review some illustrative cases that illustrate the clinical utility of the genomic assays that I will be discussing. As you just heard, I am the Chief Medical Officer for Agendia, but prior to that time was very active in clinical medicine for nearly 30 years in Los Angeles at Cedars-Sinai as well as UCLA. What I'd like to talk about today are the data supporting the functional genomic profiling that is provided by the MammaPrint and Blueprint assays. MammaPrint is a 70-gene assay which identifies the potential for distant metastasis and will classify a tumor as having either low or high risk for distant metastasis. And as I will show you in a moment, there are further stratifications within these categories that are clinically relevant. Blueprint is an 80-gene assay based on gene expression, which identifies the signaling pathways driving cancer growth and will classify tumors as being hormonally driven or luminal type, HER2 driven or HER2 type, or driven by neither of these known pathways and classified as basal type. These assays are routinely performed on formalin-fixed paraffin-embedded tissue samples, either the formal surgical resection of the primary tumor or from the core needle biopsy. And I'll emphasize that very little tumor tissue is actually required to obtain this essential genomic information. Together, these assays provide comprehensive functional genomic profiling and classifies breast cancers into multiple subtypes based upon the MammaPrint and Blueprint analysis, all of which have clinical relevance. What we'll be focusing on primarily today is the fact that these assays identify 5 different subtypes of estrogen receptor positive breast cancer. as I will discuss in a moment, each of which behaves differently in response to therapy and in terms of clinical behavior. A moment to discuss the background of MammaPrint. MammaPrint began as the result of a research endeavor over 2 decades ago, in which the question was asked, which breast tumors are able to metastasize early, as these are the tumors that clearly would need neoadjuvant or adjuvant chemotherapy rather than simply endocrine therapy. So the original paper published here nearly 20 years ago described the 70 genes that were in the MammaPrint assay. These 70 genes identify those tumors that either have a low or high risk of distant metastasis. And not surprisingly, all of these 70 genes are involved in one or more of the 7 steps in the early metastatic cascade, beginning with growth and proliferation through angiogenesis, local invasiveness, ending with the micrometastasis, where there is adaptation to the microenvironment and growth at the secondary site to become a clinically evident metastasis. The clinical utility of MammaPrint and Blueprint for chemotherapy and endocrine therapy planning is outlined here. And the data I'll review with you indicates the chemotherapy planning utility, and I'll also cover some of the endocrine therapy planning utility, something which is not typically as thought of with genomic profiling of early stage breast cancer. MammaPrint, as you know, was completely validated with the MINDACT prospective randomized trial. Nearly 7,000 patients enrolled in this large trial involving multiple centers around Europe. The data were first reported in 2016 in the New England Journal of Medicine, at which time 60% of the patients had 5 years of follow-up. And most recently, as you may know, in ASCO 2020, and then subsequently in a publication this year, the long-term results of this landmark study were presented here in the Lancet Oncology earlier this year. The results from MINDACT are well known. The primary endpoint was distant metastasis-free survival in women who were MammaPrint low risk, but clinically high risk. The design of the MINDACT trial was to determine whether those women who appeared to have clinical features that would require chemotherapy could safely avoid chemotherapy if they were found to be genomically low risk by the MammaPrint 70 gene assay. In order to do this, women with clinically high risk features, such as larger tumors, positive nodes, higher grade, were randomized to be treated with chemotherapy and endocrine therapy or endocrine therapy alone. What you see here is the 5-year distant metastasis-free survival for those clinically high-risk, genomically low-risk women who received only endocrine therapy, an excellent outcome of 95.1% distant metastasis-free survival. These data were consistent throughout the long-term follow-up of the MINDACT cohort. One of the most important findings, and the first such finding of its kind, was in the lymph node positive population. Here you see the estrogen receptor positive, HER2 negative patients with 1 to 3 positive nodes, first reported in the 2016 data and with follow-up in the 2020 and 2021 8.7-year data. What you see is that the clinically high-risk MammaPrint low-risk group received chemotherapy in the red line or no chemotherapy in the blue line. And these blue lines and red lines on the left are superimposable, indicating no real benefit to chemotherapy in this population. This was the first genomic assay with prospective randomized data in 1 to 3 positive node patients, and led, of course, to MammaPrint being the first genomic assay to be approved by the ASCO guidelines to be used in lymph node positive patients. In the follow-up data presented this year and last year, of course, the data remained consistent and robust in that there appears to be no significant benefit to the addition of chemotherapy for node-positive women who are MammaPrint low risk with estrogen receptor positive, HER2 negative breast cancer. Now, moving beyond that no chemotherapy question that MammaPrint answered, there are now new data allowing the use of MammaPrint to also guide endocrine therapy. Within the MammaPrint low risk index, we identify two categories, ultra low and low risk that is not ultra low. Data looking at this particular subset were published in 2017 in JAMA Oncology, in which an analysis of a cohort from the Swedish tamoxifen trial was undertaken. This was undertaken because within the MammaPrint low risk index, it had been observed in previous cohorts that there was a group that had an extremely good prognosis with over 10 years of follow-up if we looked at the range of the index above plus 0.355 within that low risk range. To do this particular analysis looked at the Stockholm tamoxifen study in which 652 postmenopausal women with tumors up to 3 centimeters and node negative were randomized to receive either surgery alone with no subsequent systemic therapy, or to be randomized in a treatment arm to receive tamoxifen primarily for 2 years in 65% of these women, with an additional 35% completing a full 5 years of tamoxifen. The point of this particular publication was that we were able to obtain MammaPrint results on the original tumor blocks and found that 19% of these patients fell into this ultra low risk cohort. With over 20 years of follow-up, we were able to show that for those patients who received any tamoxifen at all, even 2 years, if they were ultra low risk by MammaPrint, they had a 97% breast cancer specific survival at 20 years. And that endpoint was 100% at 10 years. The group that received no systemic therapy whatsoever had a 94% breast cancer specific survival at 20 years if they were MammaPrint ultra low, identifying for the first time in this analysis of a prospective randomized trial the excellent outcome and excellent prognosis of ultra low risk MammaPrint patients with less than the standard of care of endocrine therapy. Here's a graphic of that result of the ultra low patients, showing that the difference between the treated arm in the solid green and untreated arm in the dotted line begins at approximately year 10. Equally important, however, are the remaining low-risk patients who are not ultra-low. They, of course, do not need chemotherapy, as the MINDACT trial confirmed. However, they do appear to benefit significantly from endocrine therapy. Their difference in breast cancer-specific survival is quite apparent, as you can see from the treated arm in dark green compared to the untreated arm in the dark green dotted line. Here, the breast cancer-specific survival is improved significantly with endocrine therapy. Beyond this trial, however, we have 3 additional trials which confirm the ultra-low risk outcomes. On the left, you see the IKA trial, which was presented at ESMO last year, with the endpoint being recurrence-free interval, and showing with over 10 years of follow-up, a cohort of patients who received either no endocrine therapy or 3 years or less of endocrine therapy. And if they were ultra low, shown in red, they had, as you can see, an excellent recurrence-free interval out to approximately 13 years. On the right is the FOCUS trial, which was presented at San Antonio last year. This was a trial limited to women over the age of 70. The endpoint here was distant recurrence. And again, the ultra low risk group either receiving no endocrine therapy or less than 3 years of standard of care endocrine therapy, also, as you can see, had an excellent outcome in comparison to the low risk patients that were not ultra low, as well as to the MammaPrint high risk patients. Both of these studies are now in manuscript, soon to be published. Lastly, and most importantly, ultra low MammaPrint risk data were presented at ASCO this year from the MINDACT trial. Within the nearly 7,000 patients enrolled in MINDACT, approximately 15% or 1,000 of these patients had a MammaPrint index in the ultra low risk range. And this particular presentation in the oral session at ASCO this year focused on the outcomes of the ultra low risk patients specifically. They were primarily clinically low risk patients, but there were some clinically high risk patients who, because of the design of MINDACT, also received chemotherapy, even though they were in the ultra low risk range. The outcomes are shown here by the endpoint of breast cancer specific survival, the same endpoint that had been used in the original STO study I just discussed. Here you can see the ultra low risk patients, those that are clinically low risk in blue compared to clinically high risk in yellow. And at 8 years, the breast cancer specific survival was over 99% for both of these groups, regardless of clinical risk. Here we see the ultra low risk patients from MINDAC stratified by the therapy that they received. The majority of the patients shown in the green line on the left received endocrine therapy alone because they were clinically low risk as well as MammaPrint low risk. You can see their 8-year distant metastasis-free interval of 97.4%. There was a group of these patients, nearly 157, who, at the discretion of the treating physician, received no adjuvant systemic therapy. Their outcome, nevertheless, was excellent, as you can see, with a 97.8% distant metastasis-free interval. Together, these 4 trials confirm the robust data supporting this ultra-low risk designation. And we now will report this category on clinical reports for postmenopausal node-negative women, as this may be helpful to consider early discontinuation for those women who are having significant toxicity from their endocrine therapy. The data suggests that less than 5 years of endocrine therapy may certainly be adequate with an excellent outcome for MammaPrint ultra low risk patients. The remaining low risk patients were also of significant relevance in another study presented at ASCO this year, which was the translational analysis of the NSABP B42 trial. The NSABP B42 trial, you will recall, was a large trial asking the question whether 10 years of adjuvant endocrine therapy with an aromatase inhibitor, in this case letrozole, would be superior to the standard of care 5 years. In order to be enrolled in this trial, originally, women had to be estrogen receptor or progesterone receptor positive and need to have completed their first 5 years of therapy without any breast cancer recurrence. At that point, they were then randomized to receive letrozole for an additional 5 years or placebo. The 10-year outcome of this original trial showed that there was indeed a benefit to receiving letrozole for 10 years with an improvement in disease-free survival of 3.3%. However, this trial did not provide any clinical indicators of which patients may achieve that particular benefit. So the purpose of this translational trial was to determine the ability of MammaPrint as a genomic biomarker to identify those women who may truly benefit from this extended endocrine therapy. The results shown here indicated quite strikingly that for the original endpoint of disease-free survival, it was the MammaPrint low-risk patients, shown in red, that had the greatest absolute benefit, 7.8%, with a statistically significant p-value. MammaPrint high-risk patients did not appear to benefit from extended endocrine therapy. An additional endpoint, breast cancer-free interval, confirmed this same finding for MammaPrint low-risk patients. When the low-risk group in MammaPrint was further stratified, as we have discussed just now, between ultra-low risk and low risk that are not ultra-low, the findings became even more striking, as shown here. Ultra-low risk MammaPrint patients did not appear to have a significant benefit to extended endocrine therapy, which is not surprising given that they appear to do extremely well with less than 5 years of endocrine. However, the low-risk patients that were not ultra-low, LNUL shown here, had a disease-free survival benefit of 9.5%, nearly triple of what was originally seen in the original B42 trial. Here is another graphic showing the significant benefit when MammaPrint is able to identify the one patient population that does appear to benefit from extended endocrine therapy, the low-risk patients that are not ultra-low. Together, the data I just described to you show the clinical utility of MammaPrint not only for chemotherapy planning as shown on the left from MINDAC, but now also for endocrine therapy planning, where within the first 5 years for those women who may have such significant toxicity that they would like to stop early, if they're ultra low, they may be able to do that safely. And now we also have data suggesting that for therapy beyond 5 years, MammaPrint low risk patients that are not ultra low are the only group that appear to benefit. I want to move quickly before we discuss our cases to discuss the other assay, the Blueprint 80 gene assay, functional molecular subtyping. We know that molecular subtyping has been provided by other gene signatures, including the intrinsic subtyping in PAM50. 9 genes overlap with the 80 genes in Blueprint from PAM50. But Blueprint does identify tumors as being luminal, HER2, or basal. This was originally validated over a decade ago and now has been used in many thousands of patients to add to the information provided by MammaPrint. The primary clinical utility of the Blueprint assay was shown in the NBreast trial, a large trial that enrolled over 1,000 patients who were receiving neoadjuvant therapy. Their tumors were classified based upon a core needle biopsy with classical pathology using immunohistochemistry and fluorescent in situ hybridization, and their treatment regimen was determined based upon that. The same core needle biopsy sample was also analyzed genomically with MammaPrint and Blueprint. And interestingly, what was found was a 22% discordance in the classification. The two main discordant groups were as follows. There was a HER2 positive group defined by IHC and FISH that was genomically more dominantly driven by hormonal signaling, or actually had absence of HER2 signaling and was found to be genomically basal. Of equal importance, and what I will focus on in the next few slides, was the estrogen receptor positive cancers identified by immunohistochemistry that were genomically basal, and despite having estrogen receptor on their surface, did not appear to have any luminal or hormonal signaling, with clinical behavior very much like a triple negative. Here's another graphic from that NBreast study, showing the rates of pathologic complete response to standard neoadjuvant chemotherapy. On the left, you see the overall PCR rate for those tumors identified by IHC as being estrogen receptor positive, 10%. However, when MammaPrint and the Blueprint subtyping assay are applied to the same cohort, we are able to further stratify with greater precision these groups and predict the likelihood of PCR. For luminal A patients, which are MammaPrint low risk and luminal, the PCR rate was 2%. For luminal B, which is MammaPrint high risk and luminal, only 6%, while the estrogen receptor positive patients that were genomically basal had a much higher PCR rate of 34%. Here's another graphic of that same result, showing that we can take that overall group of ER positive patients with a 10% PCR rate and further stratify their likelihood of PCR quite significantly, showing a major difference between luminal patients and basal patients, even within this ER positive population. In this trial, 13% of all ER positive patients were classified as genomically basal by Blueprint. And in other studies, such as the I-SPY trial, which is limited to MammaPrint high-risk patients, 29% of MammaPrint high-risk patients that are ER positive were genomically basal. So this subtype is not an unusual group, but is hidden, I would say, within the estrogen receptor positive population. Now, the standard pathology on these ER positive basal cancers is quite interesting, because although one might expect that these would be the tumors with low estrogen receptor protein expression, that is not entirely the case. The range of estrogen receptor protein expression can be as high as 99%, and there's a significant proportion of these patients that have very high levels of estrogen receptor protein. Progesterone receptor can also be present, but rarely above 50%. When one looks at the PCR rates compared to IHC-defined triple negative breast cancers on the right, one can see that the ER-positive basal breast cancers behave very similarly to triple negative breast cancers and are quite different in their chemosensitivity compared to the rest of the estrogen receptor positive patients that are genomically luminal by Blueprint. Beyond the PCR differences, however, there are also consistent differences in outcome, as shown from this trial at San Antonio last year, where 5-year outcomes were presented. Shown here on the left are those estrogen receptor positive, genomically basal tumors by Blueprint, stratified for their outcome over 5 years as to whether they achieved a PCR or not. So the distant metastasis-free survival was excellent for a genomically basal tumor if a PCR was achieved in the green line. However, if PCR was not achieved, the 5-year distant metastasis-free survival was quite poor at 58%, quite similar to what we would expect to see from a true triple negative population. When one looks at the entirety of MammaPrint high-risk patients in the ER positive group, we are able to split them, as you can see, into those that are genomically basal by Blueprint or genomically luminal by Blueprint. And there is further difference in their clinical behavior, as you can see, with the ER positive basal tumors doing consistently worse, although there is an improvement in their outcome with the achievement of a PCR. Now, within the high risk group, there is a further stratification that has been observed in the neoadjuvant I-SPY trial, in which, as I mentioned, only MammaPrint high-risk patients are enrolled, particularly in the estrogen receptor positive population. I-SPY, as you may know, is a trial in which patients are enrolled and receive neoadjuvant therapy, either a standard of care arm or a standard of care plus an experimental targeted therapy arm. When these patients stratified by MammaPrint as a biomarker required for enrollment is analyzed, what one sees is that the increasing risk within the high risk range is associated with an increasing likelihood of pathologic complete response to standard chemotherapy, as shown in the dark blue boxes. The MammaPrint high risk range runs from 0 to minus 1.0, and the high risk index is now stratified at the point of minus 0.57, where we identify MammaPrint high 1 versus high 2. Now, this distinction has been important in the experimental arms, showing increased sensitivity for the high 2 group to targeted agents such as immunotherapy with pembrolizumab or PARP inhibitors. However, as I mentioned, the most important and clinically relevant factor now is the chemosensitivity, which increases with the increasing negativity in the high risk range. So together, the data I've shown you provide an algorithm that can be applied for any newly diagnosed patient, either in the preoperative setting or postoperative setting. Because we are able to obtain MammaPrint and Blueprint on a core needle biopsy with a rapid turnaround time, these data can now be employed for making preoperative decisions as well. With both MammaPrint and Blueprint, tumors may be stratified into one of these categories: luminal A ultra low, luminal A low, where they may go directly to surgery or be considered for neoadjuvant endocrine therapy. In the MammaPrint high risk group for estrogen receptor positive patients, they may be luminal B high risk or ER positive basal high risk. And we could also further stratify even the luminal patients into high 1 and high 2, as I mentioned. The importance of this is that the ER positive basal patients are really the best candidates for neoadjuvant chemotherapy. And with that, I will turn over the presentation to my colleague, Dr. Alberto Montero.
So I had 4 cases that I wanted to present, sort of illustrate, I think, the versatility of the genomic information that we get with MammaPrint and Blueprint. So in the first case is a 52-year-old patient who presents with a 2-centimeter tumor. On screening mammography, patient was postmenopausal. She clinically had no lymph nodes involved. She underwent a core needle biopsy, and radiographically there was an abnormal lymph node, which was not palpable, and that was also biopsy. In this slide, you can see on the top the H&E for the lymph node and the breast mass, And then below, you can see the immunohistochemical staining. So the patient had a highly ER/PR positive HER2 negative tumor. This is her MammaPrint and blueprint. So the patient had a luminal A low risk MammaPrint. So because of her low risk MammaPrint, as data that Dr. Ade presented, neoadjuvant chemotherapy really would be of no significant benefit. So the patient agreed to proceed first with lumpectomy and sentinel lymph node procedure. The final pathology revealed a 2.2 centimeter grade 2 invasive carcinoma with 1 out of 3 lymph nodes positive. The patient, as far as adjuvant therapy, underwent adjuvant radiation and is currently on hormonal endocrine therapy on an aromatase inhibitor and adjuvant Zometa. This is the classic MINDAC case and this was exactly what the trial was designed to address. So patients who have clinical high risk, in this case, lymph node involvement and genomic low. So what do you think, Dr. Ade, is important to add here on this case?
Well, I think this, as you say, was a typical MINDAC patient who will do extremely well with endocrine therapy alone. And the consideration now of preoperative endocrine therapy has become very important in the COVID era. There are a number of guidelines that have been proposed to suggest the safe use of preoperative endocrine therapy, where the expectation is that with a patient like this, one could allow for delay of surgery if that's necessary, but also expect some tumor response as well.
Yeah, absolutely. I think, in cases where, and this is a value that we see at our institution because we obtain MammaPrint on all core biopsies, and we discussed this at Tumor Board. So certainly in cases where surgery might have to be delayed, neoadjuvant endocrine therapy for this patient or a patient like this would make complete sense.
Yes.
So the next case is a 55-year-old postmenopausal patient who presents with a rather large 4-centimeter mass that she had self-detected. She had palpable axillary nodal involvement. Core biopsy of the breast lesion and lymph nodes were performed. And when this patient presented, it was last year during the peak of the COVID pandemic and was understandably anxious about coming in for treatment because of it. This depicts her biopsy. So on the top is H&E slides of the breast and lymph node respectively. As you can see, the patient has a high-grade invasive carcinoma, and below are the immunohistochemical tests. So this patient had also an ER/PR positive HER2 negative tumor. And this is the patient's MammaPrint and blueprint. So the patient had a high-risk luminal B tumor. So the patient is clinical high risk and molecular high risk based on the tumor size greater than 2 centimeters, grade 3 and lymph node involvement. The patient was very much interested in neoadjuvant therapy as her providers were interested in potentially downgrading her axilla. So the patient consequently underwent neoadjuvant chemotherapy with dose-dense AC and weekly paclitaxel. And she had an excellent clinical and pathologic response with a complete pathologic response. So Dr. Ade, are you surprised at all about the PAS-CR? You had presented data overall, the PAS-CR luminal B is low, but could you comment on how the quantitative score gives you a clue on the probability of a PAS-CR in a patient?
Yes, absolutely. I think this case really illustrates very well the importance of the specific MammaPrint index. This patient, as you pointed out, had very strong estrogen receptor and progesterone receptor staining. And so even with the grade of 3, this is a large tumor with positive nodes. In the era of COVID, it would not have been unusual for some clinicians to have thought this was a patient with such strong ER and PR expression to simply treat this patient with neoadjuvant endocrine therapy. That probably would not have been the best choice for this patient because what the MammaPrint revealed was not only that she was high risk, but in the high 2 category with an index of minus 0.7, which, as we saw from some of the I-SPY data, predicts a higher likelihood of PCR. So that overall luminal B PCR rate of 6% includes both high 1 and high 2. But as evidenced by this particular patient, because of that higher point in the negative index, she was identified as a chemosensitive patient. She, of course, still does need her endocrine therapy. She clearly has high sensitivity to chemotherapy as well.
Yeah. Also, I find it interesting that the data you presented, B42, also gives us some useful information. So one of the things that I would struggle with this patient is, normally we would recommend endocrine therapy, although we know that patient had a path CR. So there's this question of how long should the endocrine therapy go? So could you just go over what, B42 would tell us for this patient?
Yes, thank you. The data from B42, as you may recall, identified only one group within the MammaPrint ranges that benefited from extended endocrine therapy, and that was the low risk that was not ultra low. MammaPrint high risk consistently and specifically in every endpoint failed to show any benefit to extended endocrine therapy. By being MammaPrint high risk, we're predicting a much higher likelihood of early events and early recurrence if they were to occur. I would hope that for this patient, that won't be the case since she achieved a pathologic complete response. But the data from B42 would suggest that she would not benefit from more than 5 years of anti-estrogen therapy.
Yeah, and that's, one of the things I find fascinating with information because, now we're getting more nuanced data and information that goes beyond simply asking a binary question regarding chemo, yes or no. So I think this definitely gives clinicians more data to make decisions with. So I'm going to move on to the third case in the interest of time. This case involves a 66-year-old woman who presented with a small 1.3 centimeter mass that was only detected on screening mammography. She was clinically and radiographically node negative. She underwent a core needle biopsy of the breast mass. On this slide, again, you can see the H&E slides on the top left. She has had a high-grade invasive ductal carcinoma that was moderately ER positive. You can see the ER standing on the top right. PR was negative on the bottom left, and then the bottom middle, HER2 equivocal, but ultimately FISH negative. This is her MammaPrint and blueprint. So the patient actually had a tumor that was molecularly classified as basal and high-risk MammaPrint. So the patient went directly for surgery as she was anxious to have the tumor excised immediately. Her ultimate pathology showed a PT1CN0 with a 1.3 centimeter grade 3 tumor and 0 out of 2 sentinel lymph nodes. This patient did undergo adjuvant chemotherapy with a non-anthracycline regimen, TC times 4, because of the high clinical and genomic risk. The patient underwent adjuvant endocrine therapy with anastrozole and Zometa, which was still offered based on the ER positivity on immunohistochemistry. Dr. Ade, so I know you went over the data, but remind us, how often does molecular reclassification occur?
Yes, this is an extremely interesting case for a number of reasons. Overall, within the estrogen receptor positive group, we find between 13 and 29% fall into this ER positive basal category. So I guess roughly about 1 in 5. There does not appear to be any correlation with clinical stage. While most of these ER positive basals tend to be grade 3, there are also grade 2 basals as well. So there really isn't any specific pathology marker that clearly identifies these patients. One of the most important points about this particular case is that she would be considered in some guidelines clinically low risk because she is node negative, she's estrogen positive, she's postmenopausal, and her tumor is a T1C tumor. In many guidelines, genomic profiling would not even be considered because of the assumption that clinically low risk patients will not benefit from that information. Here's a case where within what appears to be a clinically low risk patient with a stage 1 tumor, her biology suggests that her tumor will behave like a triple negative from all the data that I've shown you. And as such, of course, we will routinely treat triple negative patients, even down to a T1B size tumor. So knowing that this patient is ER positive basal, I think will make a significant difference in her management, and really illustrates the importance of this kind of genomic profiling to better understand how a tumor like this is likely to behave.
Yeah, I think, with this patient, we're fortunate that we get the genomic testing on the core biopsy, and it really definitely enhances and informs our tumor board discussion. So with the small tumor, it was felt that the patient really didn't need preoperative therapy, but having that information definitely helps make that decision, particularly on the endocrine versus chemo question. I think this case also really illustrates, and something that we all struggle with, is how different paradigms will lead us to make different conclusions and recommendations. So if we just follow the clinical pathologic immunohistochemical paradigm, we would come up with a very different conclusion than the molecular paradigm. And so I think where the two sort of intersect, although there's some ambiguity, I think it does help us really maybe make better clinical decisions. So I think one thing I would struggle with this particular case is the question of anthracycline versus non-anthracycline. I always worry about cardiac toxicity. So in a patient who's node negative and has a smaller tumor, I would be very hesitant to add an anthracycline. But the data you presented, Dr. Ade, demonstrates that biologically these tumors behave like triple negative. So it wouldn't be unreasonable for somebody to say, well, maybe anthracycline taxane might be what's indicated. There's just no data, but I find it fascinating how nuanced our discussions now have become.
Yes, I absolutely agree. If one considers these genomically basal tumors to be identical to what we think of as a triple negative breast cancer, then it's reasonable to ask the question, would you give the same chemotherapy regimen to this patient if she were triple negative versus a high risk ER positive that was luminal, let's say? There certainly are many oncologists who, as you're pointing out, Dr. Montero, would be considering an anthracycline for an IHC-defined triple negative. And I think the data are sufficient to ask that same question for an estrogen-positive genomically basal tumor identified in this manner. And the evidence of dramatically increased chemosensitivity, as shown by those PCR rates, I think supports that. But of course, there's always the concerns about anthracycline and patient age. There's one more point I'd like to make before we go to the question and answers for the time remaining. And that is, as you can see here, the NCCN guidelines about neoadjuvant therapy and gene expression assays in the workup. Neoadjuvant therapy is primarily considered for triple negative and HER positive patients because of the high expected PCR rates. And we now have an estrogen receptor positive group identifiable by Blueprint, namely the ER positive basals, that have an equivalently high PCR rate. So I really think the data suggests that ER positive patients, if they're ER positive basal, should be considered just as readily for neoadjuvant therapy based upon gene expression as triple negatives and HER2 positives. Thank you for the case discussion.
Yeah, I think it's fascinating. We have one last case, which is very straightforward, but very interesting. This case is a 74-year-old patient who presents with a mammographically detected 1 centimeter tumor, clinically and radiographically node negative. She underwent a core biopsy of the breast lesion. Here we can see again the H&E slide. So unlike some of the other cases that were presented, this patient has invasive lobular carcinoma grade 1, highly ER/PR positive, and HER2 negative. She had mammoprint and Blueprint, which demonstrated not only luminal A subtype and not only low risk, but ultra low risk with index of 0.553. So this patient underwent surgery. She underwent adjuvant radiation therapy and was taking anastrozole, but was unhappy with the side effects, thinning of the hair, arthralgias, myalgias, weight gain, and wants to consider stopping endocrine therapy. So Dr. Ade, as you know, I'm very passionate about the ultra low, and I see a lot of value in the data, but you presented 4 trials: the STO, the IKA Focus trial, and MINDAC. So you know how I feel about it, but how compelling do you think that the data from those 4 trials is regarding curtailing or remission of endocrine therapy in general in patients like this one?
As you point out, with 4 trials showing consistently the same excellent outcome for women, primarily postmenopausal and node negative, who are mammoprint ultra low with less than the standard of care, I think the data are certainly sufficient to use that information to consider early discontinuation of therapy in the face of side effects. I think the standard of care remains to embark upon the standard 5 years of endocrine therapy. But in the case of significant toxicity, the presence of an ultra low risk mammoprint does allow for early discontinuation of therapy. And I'll point out that the majority of those trials, other than MINDAC, did not use aromatase inhibitors. They used tamoxifen, which we would all agree is somewhat inferior to aromatase inhibitors as the current standard of care. So a short course of aromatase inhibitor may be adequate in an ultra low risk patient. And this woman appears to be someone who could safely stop early and still have an excellent outcome.
Thank you again, Dr. Ade. It was a pleasure for me to present with you. And I think it's time for the question and answer session. So we're going to hand off back to Dr. Sakhya.
Thank you very much, gentlemen. Fascinating presentations. Let's take some questions. I'm very conscious of time. Our audience have dedicated time for this webinar, and there's a lot of information. So I'm going to ask you to make your answers pithy, right? So, and I'd like to get some interplay. So it's nice to have both of you respond. The first one is probably reflective of my limited intellect because I'm merely a surgeon, but can you please elaborate the name of the... Look, also bear in mind, when I went to medical school, this stuff wasn't there, right? This is new to older physicians like me. Can you please elaborate the name of the important genes associated with high, low risk grading of breast cancer used in MammaPrint?
Well, the 70 genes are listed. They're well known and available. They are not weighted. There are specific genes that are weighted more heavily than others. So they are all available for anyone's perusal. But as I pointed out, they are involved in multiple different steps. There are genes, for example, that are related to the P53 pathway that are critical in the 70 genes. There are proliferative genes. There are some estrogen response genes. So there's a wide variety, but no one gene is weighted more heavily than the other when we develop our result.
Excellent, thank you. And can I ask you, is it likely that this retinue will grow over time as we learn more?
It's unlikely that we're going to modify the original 70 genes because of the manner in which they were identified, but we are certainly adding additional signatures that will provide further specificity. That, of course, was the case with Blueprint, where we added that additional 80 that is combined with MammaPrint. And we now have other signatures in development, which will be helpful in identifying responsiveness to specific drugs, such as immunotherapy, PARP inhibitors, other ways of identifying sensitivity to DNA damaging agents. So we believe that's the direction that needs to be taken with new signatures. Although, Dr. Montero, what would you like to have in your hands in terms of a genomic signature to add to MammaPrint and Blueprint?
Well, we sort of talked a little bit before the session. One of the questions is the potential role of CDK inhibitors as adjuvant therapy, but we really don't have a lot of biomarkers. So we have data with adjuvant benefit of abemaciclib in high-risk patients. So I think for me it'd be great, because I sort of struggle with who really needs CDK inhibitors, which can add expense and toxicity. So to have a personalized signature that could help suggest who would benefit, I think that would be really important.
So I'm going to remind you, pithy chaps, pithy.
Sorry.
It's all right. This is important.
I'll make mine a haiku next.
I love it. I want to get to as many as possible. How reliable is testing from a core biopsy, and how long does it take to get results for an impatient chap like me?
So we've done analyses comparing the concordance between the core biopsy and the primary tumor with no treatment intervention in between those two samplings. And we find the concordance rate to be over 90%. That concordance rate actually is as good, if not better, than the concordance for routine markers such as ER, PR, and HER2 in terms of the intrinsic tumor heterogeneity that we understand is present. But to be as pithy as I possibly can be, what I'll say is that we've been accepting the concordance between core and resection for IHC markers for over a decade and a half to make neoadjuvant therapy decisions. And so now we can clearly show that the genomic assays are every bit as concordant as those and are quite reliable. The turnaround time is approximately 5 days from the point that the sample is received in our laboratory.
I can corroborate the turnaround time of about 5 days. So, at my institution, our pathologists were wise enough to run it on our cores, which I think is great.
Yeah, timing is everything, and putting the patient at the center of this and remembering the anxiety they deal with. So lots of questions flooding in. I'm going to try and rattle through them. Should we give adjuvant Herceptin if HER2 enriched by Blueprint, but HER2 negative by IHC fish?
I'm going to say no. That's my response.
That's certainly brief. William.
It's less than 13 syllables.
We do not have data to indicate that. If a tumor is HER2 positive by Blueprint, indicating that the pathway is on, but there is no evidence of HER2 amplification, that tumor may still be driven by the HER2 pathway. There may be a kinase mutation, for example, but in that case, we're not certain that a monoclonal antibody would be the therapy for that. So that would still be in the experimental realm. But I certainly think it warrants analysis because of that discordance that we're seeing in some cases.
So I've got one here, and I think this is going to be our last question. Does ultra low risk MammaPrint correlate with, I don't know if you can see the questions as well, William, and Alberto, does ultra low risk MammaPrint correlate with Oncotype DX estimate 11?
The answer is no. The recurrence scores are based upon the assumption that 5 years of endocrine therapy will be given. So when there's a low recurrence score, whether it's 0 to 11 or something else, that's with the assumption that 5 years of endocrine therapy are going to be given and completed. That 0 to 11 means clearly no benefit to chemotherapy according to their data, but that's not without therapy. Ultra low is truly prognostic. This was found from patients who were untreated, so they do not correlate at all. This is the only assay of which I'm aware that is routinely available that can identify these patients that can do very well with less than standard of care. I know, Alberto, you have an opinion about this as well.
No, I actually agree with what you said. I think the key thing is that although they're both genomic tests and they're on NCCN and they're legitimate tests to use, the problem with Oncotype is that its score is predicated on 5 years of endocrine therapy. So you can't really utilize that as assessing what someone's prognosis is with local treatment alone.
Well, sadly, gentlemen, that's all that we have time for today. And before I wrap, I'm going to ask both of you to give us a final takeaway message to emphasize key facts. It'd be fantastic if you could make it as a haiku. That would be awesome. We could start a whole new thread in medical communications. While you think about that, I want to thank both of you for your excellent presentations and, frankly, all that you do for patients. And remember, we're all going to be patients sooner or later. I also want to thank EMG for hosting and managing all the technical elements that are way beyond my ken, and to thank Agendia for their support, and frankly also you, our audience, for taking the time to watch this webinar so that you can better help patients. So hopefully with that, that farewell, you will have had a chance to think of something pithy. Alberto, would you like to go first?
Well, I want to thank everyone as well for attending, and I think that MammaPrint, with each new study, gives us more data to manage patients.
Again, thank you for your hosting of this event, and thank you all for attending. My point is simple and straightforward. Genomic information is essential to making the right decisions and the best decisions for women with early stage breast cancer. MammaPrint and Blueprint provide the most comprehensive analysis that's available. And as you can see, because of the complexity of breast cancer, clinicians and women with breast cancer really need this information to make the best choices.
Absolutely. Well, thank you very much again, gentlemen. Really appreciate it. And to all of you out there, stay safe, stay well, stay curious. Bye for now.